alaikum wa rahmatullahi wa barakatuh, guys. Welcome back to the channel. In the previous video we have discussed about up to the clinical features we discussed about ARDS. Now we'll proceed forwards for investigations and management. So investigations which are required are pulse oximetry, arterial blood gas analysis, FiO2. This you will measure with FiO2 based upon the delivery device, or if the patient is on mechanical ventilation, you will calculate it from BiPAP or CPAP machine. It will be shown in the or nasal cannula. Different devices have different FiO2. As we have discussed in the chapter of respiratory failure. Chest X-ray. This is to see the whiteout lungs, or HRCT thorax. Same you will see. 2D echo, sometimes it is required if there are particularly if there are no risk factors for ARDS and you have to exclude cardiac pulmonary edema, then you should do 2D echo. Along with other required investigations which are causing ARDS, or if the patient, to see whether the patient is going into DIC, all these things. Along with those investigations, these are required. This ABG FiO2 will help in diagnosing the ABG FiO2, chest X-ray, HRCT thorax. All this will help in diagnosing and gauging the severity of ARDS. So this is the X-ray of a ARDS patient. So in the X-ray phase, which shows bilateral opacities, white lungs. Consistent with pulmonary edema. These opacities are due to pulmonary edema. Difficult to distinguish from left ventricular failure. Massive pulmonary edema. White lungs. And this is a CT scan of a patient with ARDS in exudative phase. You can see predominant dependent alveolar edema and atelectasis. Predominant. Here also it is there, but predominantly it is in a dependent position on the back side if the patient is lying down. So more there will be dependent alveolar edema and atelectasis. That's all. So P plateau, what is P plateau? I forgot to tell you in the previous video. P plateau is nothing but plateau pressure that is measured 0.5 seconds at the end of inspiration. This is the definition of plateau pressure. Plateau pressure according to Harrison. 0.5 seconds after the end of inspiration which you measure. And plateau pressure, the difference between the plateau pressure and peak inspiratory pressure is known as driving pressure. That is important. We'll see in the management. Plateau pressure is also shown in the monitor when the patient is connected to mechanical ventilation. So what strategies we will use and what is the funda behind that strategies? What is the concept behind that strategies? So our goal is to sustain the gas exchange. Sustain the gas exchange so that the patient can, or the lungs, till the patient or the lung pass through this critical phase, and patient should sustain life. And along with that, you are using respiratory supports. So respiratory supports, as we have seen in the pathophysiology, they cause iatrogenic damage to the lungs. Iatrogenic damage, they itself damage the lungs. Avoid ventilator induced injury, nothing but really. How it causes? Due to pressure, volume, and excessive oxygen, and atelectasis. These are the four mechanisms by which ventilation can cause damage. So you need to adjust the respiratory support so that the patient can pass the critical phase without having any additional injury from the respiratory support itself. That is the main critical strategy behind handling the patients of ARDS. So pressure is, how does pressure damage? You will apply pressure to open the alveoli and to push the air in the fluid filled alveoli. So what happens is, so in pressure, when you apply, this is the fluid filled alveoli, this is collapsed alveoli, this is normal alveoli. You are applying pressure to push air into this and to open this. But what happens is, this is already stressed by oxygen, by fluid. You are applying pressure, you are going oxygen, so this will cause increased stretching of this alveoli. That will cause trauma to that alveoli. And you are applying more pressure to this, but this alveoli is already normal. Some alveoli are already normal. They are already having normal gas exchange. So that pressure will cause over distension of this alveoli also. That causes barotrauma. Barotrauma. That is how the pressure PEEP. That PEEP causes injury. And volume also does same. Increased volume of oxygen you will give because of over distension there will be trauma to the alveoli. Atelectative trauma is nothing but when you give air, the collapsed alveoli will open. When the air is and during expiration, the alveoli will collapse. So this is atelectative trauma. So repeated distension and collapse of the alveoli will cause injury to the alveoli. That is atelectative trauma, that is prevented by giving PEEP. Okay, this PEEP adjustment is the mainstay of management of ARDS. Then so one is hyperoxia, increased oxygen. Oxygen itself causes injury to the lungs by generating free radicals. So that's why in ARDS you keep FiO2 less than or equal to 0.5, and if required, if you want to maintain saturation, if you want more oxygen, instead of increasing this FiO2, you will increase peak and expiratory pressure. So this will cause recruitment of more collapsed alveoli. They will open and they will have gas exchange. So instead of increasing FiO2, will increase PEEP. This strategy is used in order to reduce oxygen-induced lung injury. That is one more type of injury due to mechanical ventilation. These are the types of injury. These are also known as ventilator-induced lung injury. So goal is to maintain gas exchange, sustain life, along with avoiding ventilator-induced lung injury. So you can now from after COVID-19. So it is books are dividing ARDS like COVID-19 ARDS or non-COVID-19 ARDS like this, because the management is slightly different in between these two, in normal ARDS and in COVID-19 ARDS. In patients on oxygen for COVID-19 pulmonary edema, dexamethasone is very important. It decreases the mortality by 28 days. So dexamethasone we have seen in those years of COVID-19. Dexamethasone was very much used actually, and I myself have seen the patient, and I myself have treated the patient with this. Patients were rushing for remdesivir injection. Patients were rushing for that favipiravir tablet. But the results were there were no trials suggesting improvement or something. Okay, but the utilization of remdesivir was so much increased that it was selling into black also. But the real thing was that remdesivir was not increasing the mortality when compared to dexamethasone. Dexamethasone was very much increasing the mortality when compared to remdesivir in COVID-19 patients at that time. I myself experienced this thing. Okay, so dexamethasone is a very important drug in cases of COVID-19 ARDS patients. So mechanisms of when you are giving respiratory support, that will cause injury to the lungs. How to avoid that? What will be the strategies? Biotrauma, nothing but pressure trauma and volume trauma. That will cause alveolar distension and mechanical damage to the lungs. How you will decrease that? Maintain the tidal value less than or equal to 6 ml per kg and Plateau pressure less than or equal to 30 centimeter of water. This one, and one more is something called as what you call permissive hypercapnia. Permissive hypercapnia or hypoxia. Permissive hypercapnia, such that permissive hypercapnia, such that the pH should not go less than to 7.2. Such that the pH should not go less than 7.2. It should be more than 7.2. So patient instead of maintaining the PaCO2 normal, you let the PaCO2 to rise until some levels. Let the PaCO2 rise and let the patient tolerate some amount of PaCO2, such that it should not change the pH less than 7.2 of the blood. Okay, so these are the studies: tidal volume less than or equal to 6, Plateau pressure less than or equal to 30 centimeter of water, and permissive hypercapnia, such that the pH of the blood should be more than 7.2. That's how you reduce biotrauma and volutrauma. Biotrauma is nothing but due to inflammation. Okay, again same, low tidal volume, you should give 6 ml per kg. Open lung strategy with high PEEP. Open lung strategy is nothing but what you do, you will recruit the collapsed alveoli by applying pressure during expiration stage of respiration. Recruit means you will take more alveoli into functioning which were non-functioning due to collapse. By applying pressure at expiration, you will open those alveoli. That is nothing but open lung strategy that you will do with by applying post and expiratory pressure, hold and expiratory pressure, because alveoli collapse mainly during expiration. So that's how you reduce the biotrauma. Atelectotrauma, so this is because of repeated alveoli and recruitment and de-recruitment. You apply pressure, those alveoli open and volume will go off, again that will close. How do you treat this? How do you manage this atelectotrauma? Again, you titrate PEEP to prevent tidal alveolar collapse. You titrate PEEP to in such a way that it should prevent the atelectotrauma. Okay, so remember tidal volume, plateau pressure, permissive hypercapnia, and PEEP. These four, and one more thing is keeping the FiO2 less than 0.6. These five are the cornerstones of management of the ERDS. These four are the cornerstones of the management of ERDS. Okay. So how do you prevent hyperoxia injury? Okay. You will increase PEEP rather than increasing FiO2 if saturation, if you want further improvement in the saturation, instead of increasing FiO2, you will increase PEEP. Okay. But one thing here it is there written, oxygen induced injury is seen only theoretically in humans. Practically it is not seen. This is given in pocket medicine. Okay. Now that's about the mechanisms by which the respiratory support causes further damage to the lungs, and how you will, by maintaining the gas exchange along with preventing the villi. So these are the measures, these are the strategies how we will prevent. Now coming to the management part. First, you will use supportive care till the lung passes through that critical period. So mainly mechanical ventilation, non-invasive ventilation, or high flow oxygen therapy may be considered in mild ARDS. Non-invasive is nothing but CPAP and BiPAP plus HFNC. These three you can consider in patients with mild ARDS. With worsening severity, you can consider intubation of the patient. Okay, this thing you remember. So how you will do? You will maintain, as discussed in here in the up side, low tidal volume 6 ml per kg of ideal body weight that prevents the volume trauma. Okay, and same things repeating. Limit the plateau pressure. Limit the plateau pressure to less than 30 cm of water, that is barotrauma. Higher PEEP requires recruits collapse level. If you want oxygen saturation is down, instead of increasing FiO2, you will increase PEEP. Okay, that's one thing. Second is oxygen target. What should be the target? That should be 88 to 92%. That is nothing but permissive hypoxia or hypercapnia, but the pH should be more than 7.2. This is to avoid oxygen toxicity. One more important point is conservative fluid strategy. You should not give more and more fluids to the patient, because again already there is fluid in the lungs. You are infusing the fluids more into the lungs. Again, that you are increasing the edema. To reduce the edema, you use conservative fluid strategy unless shock is present. Shock is present, you need to give fluids. So till that time you use conservative fluid strategy. What is that conservative fluid strategy? You maintain a borderline fluid balance. Okay, borderline fluid balance. And if there is hypervolemia, if there is hypervolemia, you can also give diuretics to the patient so that edema gets reduced if there is hypervolemia. So you maintain borderline fluid status of the fluid balance of the patient. So that is conservative fluid strategy. So these are the main strategies. What are those main? One is mechanical ventilation, and what are the adjustments should be made to the mechanical ventilation. Second is oxygen target. Third is conservative fluid strategy. So these have good evidence that the patient, the mortality of the patients are reduced by these strategies. Adjuncts to that strategies. So prone positioning, these are used in severe ARDS patients. Prone positioning, what it does, it opens the some part of the lungs which are normally collapsed. Okay, when you keep the patient in the prone position, those areas of the lungs will open and the oxygenation will improve. That is the funda behind that prone positioning. So in more than 12 hours per day you will give, that will include the V by Q matching in patients who have severe ARDS. You will do this, and this should be individualized because the patient will have tube in their mouth, they will have nasogastric tube, and when they have intubation, they will be maintained on anesthetic agents that will decrease the BP of the patient. Okay, all those things will be when you give the patient, when you try to rotate the patient, that the tube can be dislodged. So that prone positioning should be individualized to the patient. So where you can do, you do, and where you can't do, you don't do. Okay, that is how you do prone positioning in severe ARDS. Neuromuscular blockade, example from cis atracurium for 48 hours. So normally intubation you give anesthesia, okay, but neuromuscular blockade, what it does, it will relax the muscles. That means you are taking over taking over control over the patient's respiration more by doing this neuromuscular blockade. Okay, so in severe cases, if the saturation is not improving, even you can try neuromuscular blockade. That reduces the oxygen demand of the patient. So when the muscles are active, they require more oxygen. Okay, and when the muscles are not active, that requires less oxygen. Along with that, what do you call, respiratory muscles will be lax. So you can extend the, you can what do you call, distend the chest easily. Okay, then glucocorticoids, these have imprecise data. Early within 7 days, less than 7 days, use of smaller doses of methylprednisolone in non-COVID-19 ADS patients. Okay, non-COVID-19 ADS patients, like methylprednisolone in doses of 1 mg per kg, or if the patient is in 7 to 14 means from the 7th to 14th day of the ARDS, you should give higher doses, like 2 mg per kg daily you should give till the patient comes out of that stage, meaning approximately 21 days. Okay, so in less than 7 days 1 mg per kg, 7 to 14 days 2 mg per kg, and these glucocorticoids should not be stopped abruptly but should be slowly tapered down over the course of 1 to 2 weeks. The use of glucocorticoids in hypoxic respiratory failure associated with COVID-19 with or without ARDS is one of the mainstays of the therapy, and here you use dexamethasone. This is the preferred drug and evidence-based in case of COVID-19 ARDS. Okay, so what are the adjuncts? Prone positioning, neuromuscular blockade, glucocorticoids. Last, in refractory hypoxemia, you use ECMO. ECMO, what is ECMO? ECMO is extracorporeal membranous oxygenation. It is nothing but your it is like your dialysis. So kidney is not functioning, not doing its job. So what you will do, you take the blood out of the patient and you give it to the machine. Machine will do that job of kidney, and that new blood, pure blood, will come back to the patient from another side. Similarly, what you will do here, lungs are not functioning properly. So for some time you will take the blood from the patient and you will give to some machine. That machine will give oxygen, will remove the carbon dioxide, and that oxygenated blood will be given back to the patient by other route. So it can be VV ECMO, venovenous ECMO, or it can be arteriovenous ECMO, AV ECMO. Okay, there are two types of ECMO. So just remember these things. Okay, these are the adjuncts. Then the third step is treat the underlying cause. This is very important, like antibiotics for sepsis, or if there is abscess, drainage also abscess, all those. Okay. Now we have learned that in PEEP, maintenance of PEEP is the corner, very among all those 5 things. PEEP titration is the very technical part of the maintenance of respiratory support in ARDS patient. So how do you do that PEEP titration? What are the methods? So the best method is unclear. So you don't do PEEP titration, only tidal volume you give titrated to the oxygen saturation. It has no benefit according to trials, according to the studies. Okay, so the best, so now in next points we will discuss different methods of PEEP titration. So the best PEEP trial, incremental PEEP titration using compliance, oxygen, hemodynamics. That you see the compliance of the lungs, oxygenation of the patient, hemodynamics of the patient. If you are able to increase the PEEP without increasing the plateau pressure, that means lung is still recruitable, meaning some diseased alveoli can be taken back into function still. Okay, therefore you increase the PEEP in those patients. When you will increase the PEEP, you see the plateau pressure. If the plateau pressure is not increasing after increasing the PEEP, then that means still some parts of the alveoli are recruitable, you can take those alveoli into function. So this is the best strategy of titration of the PEEP, starting from the lower side to the upper side. So you will increase the PEEP if saturation is increasing without increasing the Plateau pressure. Without increasing the Plateau pressure means the Plateau pressure is maintained below 30 centimeter of water, equal to or less than 30 centimeter of water. So what happens then? This reduces the time on ventilator machine and better lung mechanics according to studies, and this also has decreased mortality according to studies. So you will see the Plateau pressure and you will titrate the PEEP according to the Plateau pressure. If the Plateau pressure is not increasing, even after increasing the PEEP, it is less than 30 centimeter of water, so that has very good decreased mortality rates and better lung mechanics. Okay, so that is the best method of PEEP titration. Second is you will have some table low PEEP strategy. So you will have a, so it means for this FiO2 you should have PEEP this much. For this FiO2 you should have PEEP this much. So in the form of table, this is available in the net, in the ardsnet.org. So according to that you will adjust PEEP according to FiO2. So according to the ARDSnet, you should manage the FiO2 PEEP adjustment. You should make according to the ARDSnet like this, which is given in the table. Strategies of PEEP by FiO2 or FiO2 adjustment in patient with acute respiratory distress syndrome. So there are two strategies mainly: the lower PEEP strategy and higher PEEP strategy. So these you can use in mild to moderate patients, and this in moderate to severe patients, this strategy. So there are two strategies. For FiO2 of 0.3 to 0.4, PEEP 5. For 0.4 to 0.5 is 5 to 8. 0.5 to 0.6, 8 to 10. 0.6 to 0.7, 8 to 10 again. Like this you will titrate the PEEP along with the titration of FiO2. So for that respective FiO2, that PEEP should be maintained. So this is another strategy by which you can titrate the PEEP. So next one is, so these two are the most favored strategies. These are some other strategies like reequipment maneuvers, stepwise preferred over sustained inflation. Evidence insufficient to recommend routine use. Reequipment maneuvers at high pressures, whether they increase mortality, we don't know. Okay, reequipment maneuvers. Okay. So next is esophageal balloon. What you will do is you measure the transpulmonary pressure with this esophageal balloon, and according to the transpulmonary pressure you will titrate the PEEP. That is the funda behind this esophageal balloon. This is used to estimate pleural pressure and thereby estimate the transpulmonary pressure, that is true airway distending pressure. True airway distending pressure. Nothing but transpulmonary pressure. True airway distending pressure. Okay. Adjusting PEEP according to esophageal pressure. So that means esophageal pressure is equal to transpulmonary pressure, and that is approximately you are measuring the distending pressure. So based on this concept you are titrating the PEEP. So adjust PEEP according to esophageal pressure to maintain optimal transpulmonary pressure. Does not change ventilator free days or mortality, although it does decreases the need for advanced risk treatment. Okay, so you will not have any change in ventilator free days or mortality if you titrate the PEEP according to this strategy. The last strategy is driving pressure. What is driving pressure? P Plateau minus PEEP is the driving pressure. So decrease in P Plateau pressure, decrease in driving pressure is associated with increased survival, and target this P Plateau pressure less than 15. So this is also an important method of titrating PEEP. If you are titrating PEEP and the driving pressure is maintained below 15, then that is associated with increased survival. So the most important, if I just go back, I think these three which we have discussed, the best is this one. You titrate the PEEP according to the P Plateau pressure. If you titrate PEEP and if the P Plateau pressure is not increasing, that is very good sign. Okay, you titrate the PEEP and P Plateau pressure is not increasing, that is very good. What does that mean, that P Plateau pressure that is maintained below 30 centimeter of water? So this is one. Here only we can take that driving pressure. So you titrate the PEEP and you maintain the driving pressure less than 15. So that is also a good thing. Okay. Other one is according to the table which is available on the ARDS net. So these are the strategies by which you titrate the PEEP. So what are the complications of ARDS? So multi-organ failure. Because of hypoxemia, there is systemic hypoxia. So that will lead to lactic acidosis, change in pH, so loss of enzymatic activity, pump failure, cellular damage and organ damage. That is multi-organ failure. And iatrogenic damage is ventilator-induced lung injury will be. So if you don't adjust the ventilator settings, which we have discussed till now, then that ventilator itself will cause injury to the lungs. One is many patients will not go into this fibrosis stage, but some patients will go on into the fibrotic stage and they will develop chronic ARDS. That nothing but chronic interstitial lung disease they will develop. Chronic interstitial fibrosis, interstitial lung disease they will develop. Interstitial lung disease. I have seen in my practice a patient who has recovered from COVID-19. Now he has developed interstitial lung disease. So that is an example for post-ARDS pulmonary fibrosis. So what is the prognosis in these patients? So mortality is very high, approximately 40% overall in clinical trials. Mortality differs depending upon the causes. So 9 to 15% respiratory causes, if they are causing the ARDS. So the causes which cause ARDS, if they are respiratory, then the mortality rate is 9 to 15%. And extrapulmonary causes like sepsis or pancreatitis or TRALI, all these have increased mortality. That means patients have less mortality if they have ARDS due to pulmonary cause, and they have very high mortality if they have if they are suffering from ARDS due to extrapulmonary cause. So that we need to remember. Okay. So the last thing is survivor. So the patient who recover, survivors, PFT will be, so till from some months they'll take time to adjust, those who survive the ARDS syndrome. But PFTs will come approximately to normal, but in spite of that, patients will have decreased diffuse lung capacity. They'll have muscle wasting, weakness. This will persist. They will experience these things. They will have decreased exhaust tolerance, decreased quality of life, increased psychological mortality. 44% of previously employed patients will be jobless at 12 months. That is nothing but approximately half patients who will undergo, who survive from ARDS, they will not be capable of doing job at 1 year. Okay, so that means that from that you can understand that this is very bad thing which a patient suffers from ARDS. So this is the summary of the strategies which we use in patients with ARDS, okay, in managing the ARDS. So you will diagnose the ARDS by Berlin defining criteria. You will treat the cause and you will resuscitate the patient initially. How will you resuscitate? You will give the respiratory support, and obviously in mild cases you can give this HFNC or non-invasive mechanical ventilation. In severe cases you will intubate the patient. So when you are intubating the patient, you will have the protective lung strategy, which we have till now. We have discussed now that protective ventilation strategy you should have. So after giving respiratory support and you are treating the cause, after diagnosing the cause, you will monitor the patient and adjust the patient. Okay, how will you monitor? You will by CT chest, by echocardiography. You will perform infection screening also, and if you have some findings like pneumothorax, you will drain that. Okay, if the BP is falling, if the patient is going into shock, you can start inotropes or pressors. But you will again, so this is given here, you will maintain the nutritional support by Rais tube, for example, and you will optimize the fluid balance. So fluid conservative strategy, we have learned, no? So those things. So you will treat the cause, you will initiate the resuscitative measures by NIV or by invasive ventilation by using the protective lung strategy. If there is, you will act on findings which make the patient unstable. So you will stabilize the patient. You will give the nutritional support and you will optimize the fluid balance. Now you will see the patient's saturation. If the patient saturation is maintained between 88 to 92, and the target which is given in these patients, in ARDS patient, is actually 88 to 92. Don't go more than 92, it will cause hyperoxia and oxygen injury. And if that saturation is less than 88, then it will cause hypoxic injury. So you maintain the saturation between 88 to 92 ideally. But if the saturation is not maintained in this range, not maintained, then you consider prone positioning, which will improve the individualizing the patient. You will consider prone positioning the patient, which may improve the saturation. You can make the patient inhale nitric oxide, that will increase oxygenation in the lungs, but this has less evidence. So evidence is good for protective ventilation strategy. Prone positioning, this one also has a good evidence. This has less evidence. But if the patient is refractory to all these measures, by protective ventilator strategy, prone positioning, inhale nitric oxide, everything you have given, and the patient is refractory, then you can consider ECMO, extracorporeal membranous oxygenation, and you will maintain the saturation 88 to 92%. Now, if the patient is only at this point the patient is maintaining the saturation, then you will see the patient whether the patient is stabilized for 2 days, meaning 48 hours. If he is stabilized for 2 days, then you will consider weaning. Weaning is nothing but you will bring down the patient from higher respiratory support to lower respiratory support, step-by-step manner, not abruptly. For example, if the patient is intubated and he is in high PEEP pressure, then you will lower the PEEP pressure first. Then after lowering the PEEP pressure, you will bring the patient on non-invasive ventilation, NIV, alternating with HFNC. Okay. If the patient is again stable on this, you will bring the patient to simple nasal cannula or non-breather mask, like that. And if the patient is again stable on that, you will go for home. For some days, you will give home ventilation for the patient. That is nothing but weaning. Now, if the weaning is successful, then outpatient you will follow the patient. If it is not successful, then reevaluate the patient and consider the cause and reassess the CT scan of the patient. So what you are doing is you are seeing what pulmonary changes are resolving or not by CT scan, and you are seeing whether the cause which you have treated is still remaining, or if it is still remaining, what we should do for that cause. So progression and cause you will monitor, and during this only you will consider steroids. Okay, if the patient is between 1 to 7 days of ARDS, 1 mg methylprednisolone, and if he is in between 7 to 10 days, 2 mg methylprednisolone. This should be tapered gradually. In patients with COVID-19 ARDS, you will use Dexamethasone, which has which decreases the 28-day mortality of patient in trials. Okay, so this is the chart. So according to this, you will manage the patient. By this, you will end the chapter of ARDS, and next I will just in the next there will be last one video on this respiratory system. After that video, we will move on to the next system, that is cardiovascular system, and we will discuss the cardinal manifestation step by step, one by one, of that cardiovascular system. Thank you for listening. Do comment.